Welcome back to another episode of Surgical Simplified. In this video, we'll explore some of the most important topics in upper GI surgery: gastroesophageal reflux disease, peptic ulcer disease, and their key complications like bleeding, perforation, and gastric outlet obstruction. Let's break it all down smooth, logical, and exam focused. Let's start with gastroesophageal reflux disease, one of the most common causes of upper GI symptoms. GERD occurs when gastric contents reflux back into the esophagus, leading to symptoms and mucosal injury. Normally, several mechanisms prevent this reflux. They include the left crus of the diaphragm, the pressure difference between intra-abdominal and intrathoracic regions, the acute angle at which the esophagus enters the stomach, and the increased tone of the lower esophageal sphincter. When these mechanisms fail, reflux occurs. Now let's look at the risk factors. Obesity is the main one. It increases intra-abdominal pressure. Pregnancy, a high-fat diet, smoking, and alcohol use all contribute to reflux as well. Symptoms typically include a burning retrosternal chest pain, acid regurgitation, and an acid taste in the mouth. Some patients develop nocturnal coughs or recurrent respiratory tract infections. The cough usually gets worse after meals. Hoarseness of voice may appear due to laryngeal irritation, and sometimes the pain can even mimic angina. If the inflammation is severe, swallowing can become painful. That's called odynophagia. Diagnosis is usually clinical, but investigations are required in three main situations: when GERD does not respond to medical management, before any anti-reflux surgery, or when the patient has dysphagia. The first line investigation is upper GI endoscopy. It helps exclude mucosal lesions in dysphagia, detects erosions and ulcers, and identifies Barrett's esophagus, a columnar metaplasia of the esophageal epithelium that can progress to dysplasia and eventually adenocarcinoma. Most Barrett's cases are asymptomatic, so a normal endoscopy doesn't exclude GERD. However, the best investigation overall is 24-hour pH monitoring with esophageal manometry, which shows reduced lower esophageal pH and reduced sphincter tone. If your exams ask for single best investigation, pick pH monitoring. Let's go for management of GERD. First line management is always conservative. Start with weight reduction. That's the single most important step. Reduce fat and spicy food intake. Stop smoking and alcohol. Avoid large meals at night and always sleep a few hours after dinner with the head of the bed propped up. If symptoms persist, aid medical therapy, typically a proton pump inhibitor plus domperidone. Surgery is only considered when symptoms are severe, reflux is large volume and resistant to medication, or in cases of Barrett's esophagus and complications like strictures. The surgery of choice is Nissen's fundoplication. For Barrett's, the mainstay is still treating the underlying reflux disease. Adjuncts like laser therapy, organ plasma coagulation, or endoscopic mucosal resection may be used, but remember, none have proven to reduce the cancer risk. If a peptic stricture forms, treat it with endoscopic dilatation. That's less invasive and ideal for short segments. If it's a long or tight strictures, it may need an esophageal bypass. Now, A quick note on hiatus hernia. It can cause reflux, dysphagia, or chest pain. Rolling, which means paraesophageal hernias, always need surgery because they risk strangulation and perforation. Small sliding hernias, on the other hand, can be managed conservatively. And always remember, dysphagia can result from extrinsic compression too. So, rule out causes like tuberculosis, lymphoma, or bronchial carcinoma. Upper GI endoscopy helps distinguish this from true esophageal carcinoma. Now, moving on to peptic ulcer disease, an ulcer that develops anywhere in the GI tract where acid and pepsin cause mucosal damage. If it occurs in the esophagus due to reflux, it's called an esophageal ulcer. Sometimes ulcer can even form in a Meckel's diverticulum because of ectopic gastric mucosa. The two main causes are Helicobacter pylori infection and NSAID use. Smoking, stress ulcer, and gastrin-secreting tumor called Zollinger-Ellison syndrome can also cause peptic ulcer disease. Most gastric ulcers occur along the lesser curvature of the stomach. Anterior ones tend to perforate and posterior ones bleed, occasionally eroding into the splenic artery. Duodenal ulcers can erode into the gastroduodenal artery. Chronic gastric ulcers can undergo malignant transformation, but duodenal ulcers never become malignant. Remember this carefully. Every patient with suspected peptic ulcer disease should undergo upper GI endoscopy. If a gastric ulcer is seen, take multiple biopsies from the edges to rule out malignancy. Even if the first biopsy is normal, repeat endoscopies are required during and after healing because an ulcerated tumor may mimic benign peptic ulcer disease. Clinically, peptic ulcers cause periodic epigastric pain. Symptoms come and go even without treatment. Gastric ulcers present with burning epigastric pain worsened by meals. So the patient eats less and loses weight. Duodenal ulcers causes pain relieved by meals. So the patients eat more, gain weight, and often wakes at night with pain. In either type, patients may present with hematemesis, melena, or iron deficiency anemia. If a patient presents with non-specific epigastric discomfort, management depends on the situation. In a young patient with no red flag features like loss of appetite, weight loss, anemia, or hematemesis, you can start a 1-month trial of proton pump inhibitors and lifestyle modification. If symptoms recur or don't improve, do an endoscopy. But in older patients or those with alarming features, always do upper GI endoscopy first to rule out gastric carcinoma. If you find a gastric ulcer, take multiple biopsies from both the edges and center to exclude malignancy beyond doubt. Features that suggest a malignant ulcer include everted edges, a necrotic center, and contact bleeding. And even if initial biopsies are negative but suspicion is high, repeat endoscopy is mandatory, and remember, a biopsy is just a sample. Even benign looking ulcers need follow-up endoscopies during and after treatment because acid suppression can temporarily mask cancer symptoms. To confirm Helicobacter pylori, you can use urease breath test or H. pylori fecal antigen test, both non-invasive. If a biopsy is taken, culture and microscopy can also detect it. Serology for antibodies isn't reliable. It can't distinguish past from current infection. When infection is confirmed, give triple therapy for 2 weeks: amoxicillin, clarithromycin, and a proton pump inhibitor. Metronidazole can substitute if needed. Continue the PPI for a month afterwards. Triple therapy is essential when ulcer occur without NSAID use. H. pylori infection increases the risk of gastric and duodenal ulcers, gastric carcinoma, gastritis, and gastric lymphoma. Now let's talk about the complications, a favorite exam area. There are three main ones: upper GI bleeding, gastric perforation, and gastric outlet obstruction. First, we'll look into upper GI bleeding. The common causes include peptic ulcer disease, cirrhosis with ruptured varices, gastric carcinoma, malarious tear, which follows forceful vomiting and causes fresh blood in later vomiters, and aortoenteric fistula, often after surgery for an aortic aneurysm. Management starts with the ABC approach. If GCS is less than 8, intubate and ventilate, connect to monitors, give oxygen, assess pulse and blood pressure, and insert 2 large bore IV lines. Send blood for cross-matching, coagulation profile, full blood count, renal and liver function. Resuscitate with IV fluid and give IV proton pump inhibitors. And if chronic liver disease is suspected, add terlipresine or octreotide plus IV ceftriaxone. Keep the patient nil by mouth. Transfuse blood for hypotension, massive hemorrhage or hemoglobin less than 8 gram per deciliter. After stabilization, we have to perform a upper GI endoscopy, preferably within 24 hours. Endoscopic options include diluted adrenaline injection, glue therapy, laser, or argon plasma coagulation. For varices, do bend ligation followed by oral beta blockers to prevent rebleeding. Recurrent banding offers the best long-term control. Indicators of a major bleed on endoscopy include a visible spurting vessel, an exposed artery, or a clot adherent to an ulcer base. If bleeding continues despite endoscopy, insert a Sangstaken Blackmore tube for tamponade and consider surgery or TIPS as the last resort. TIPS is preferred if available. Now let's go for gastric perforation. This usually presents with sudden severe epigastric pain on a background of peptic ulcer disease or NSAID use. The pain later becomes generalized and fever may follow due to peritonitis. On examination, there is absence of liver dullness and signs of peritonitis. The erect chest X-ray is the investigation of choice, showing air under the diaphragm. In stable patients, a CT abdomen is the gold standard and can exclude perforation if normal. Management for gastric perforation again begins with resuscitation, IV fluid, blood for cross-matching, antibiotics, analgesics, and keep the patient nil by mouth. Inform theatre early and perform urgent laparotomy with peritoneal lavage. Start IV PPIs even before surgery. Afterward, maintain gastric decompression with a NG tube and continue PPIs. Finally, treat the underlying cause. Now let's move on to gastric outlet obstruction. This occurs when healing of a gastric or duodenal ulcer causes fibrosis and narrowing. It presents with projectile, non-bile stained vomiting of food eaten days ago. On examination, you may hear a succussion splash and find dehydration. Because of loss of hydrogen and potassium ions through vomiting, the patient develops hypokalemic metabolic alkalosis. Dehydration reduces renal perfusion, therefore it activates renin-aldosterone angiotensin system. It causes paradoxical aciduria and further potassium loss. This classical metabolic pattern isn't seen if the obstruction is due to malignancy. Treatment of gastric outlet obstruction begins with stabilization, IV normal saline with potassium supplementation. Do NG decompression, give IV PPIs, and keep the patient nil by mouth. Once the stomach is emptied, perform upper GI endoscopy and biopsy the stricture to rule out cancer. Sometimes conservative management alone works, but persistent obstruction may require endoscopic dilatation or distal gastrectomy with gastrojejunostomy. Unexplained melena. If a patient presents with unexplained melena, first try to locate the bleeding site. It can be stomach, duodenum, small bowel, or right colon. Start with upper GI endoscopy. If it's normal, do colonoscopy. If both are normal, evaluate the small bowel by enteroscopy or capsule endoscopy. Still negative? Try RBC scanning or selective angiography. Surgery for peptic ulcer disease is rare today. It's mostly reserved for complications. That brings us to an end of this episode of Surgical Simplified. We have covered the key upper GI topics from reflux disease and peptic ulcers to bleeding, perforation, and obstruction. If you found this helpful, make sure to like, share, and subscribe to MedVibes for more simplified, exam-ready surgical explanations. Until next time, stay curious, keep learning. And this is Surgical Simplified signing off.